Hello, everybody. Welcome to Global Response to COVID-19. This is webinar number 15. This meeting is supported by the Panamerican Trauma Society, American Association for Surgical Trauma, International Relations Committee, World Coalition for Trauma Care, and sponsored by University of Miami and Virginia Commonwealth University, VCU. Just remember, the meeting has been recorded, and the meeting will be you agree to have your image recorded. I would like to ask Dr. Stefan Foianini, Treasurer of the Panamerican Trauma Society, to please introduce the panelists.
Thank you so much, Dr. Martos. It's a pleasure to have a distinguished group of panelists with us today. Dear friend, Dr. Marc Moya, who's Professor and Chair of Trauma at the Medical College of Wisconsin in the United States. Dr. Hayato Kurihara, who's participated in many of these webinars. He's Associate Professor and Head of Emergency Surgery and Trauma Unit at Humanitas Research Hospital in Milan, Italy. And Dr. Tina Gaarder, Director of Trauma and Consultant, General GI and Trauma Surgery at Oslo University Hospital, Norway. Amongst the panelists, we have Dr. Carlos Starling. He's an infectious disease specialist from Belo Horizonte, Brazil. Dr. Rafael Barrera, who's Director of Surgical Intensive Care Unit at Northwell Health Long Island Jewish Medical Center in the United States. Dr. Ken Buffer, Emeritus Professor at the Department of Surgery in South Africa. Dr. Raul Coimbra, well known to the whole panel, Executive Director of the World Conference of Trauma and Surgeon-in-Chief at Riverside University Hospital and at Loma Linda University in California. Dr. Thomas Calea, PTS Executive Director, Professor of Surgery at Adams Cowley Shock Trauma Center, Baltimore, Maryland, and Dr. Felipe Vega, current President of the Pan American Trauma Society and Trauma Surgeon at the Department of Surgery at Hospital Angeles Lomas, Mexico City, Mexico.
Thank you, Dr. Foianini. Now I would like to ask Dr. Raul Coimbra, Executive Director of the World Coalition for Trauma Care, to please welcome all the international societies joining us today.
Thank you, Antonio. So on behalf of the World Coalition for Trauma Care, Pan American Trauma Society, and the WCTC, I welcome all the professional organizations listed on the slide and their members attending the webinar number 15. As I always say, this is a tremendous accomplishment of this group of professional organizations coming together under Antonio's leadership at the University of Miami with the help of VCU to put this together. So welcome all, and I hope you guys enjoy today.
Thank you, Dr. Coimbra. So I'm going to start now with the first presenter. Will be Professor Marc Moya, Professor and Chief of Trauma Acute Care Surgery at Lunda, Aprahamian Chair at Medical College of Wisconsin, United States. Dr. De Moya, thanks for joining us today. Would like to start. We want to hear your nice presentation. Thank you very much.
Great, thank you, Dr. Martos. And good afternoon, good morning, good evening across the globe to the participants. It's great to be here with you today, and I thank you for the opportunity to discuss a little bit about what we're doing here in Wisconsin, just to familiarize people with where we exactly are. Here's the map of the United States. Here's Chicago. This is the Midwest United States of the Great Lakes. And Milwaukee is just north of Chicago on the west coast of Lake Michigan. This is the map population-wise that has to do that points out the number of COVID cases across the United States. This is through Johns Hopkins, which many of you have seen. One of the other data points on their website, just that I wanted to highlight, was the map of each of the states, because there has definitely been variability between the states. And some of your countries actually may, correspond to one of these curves in our 50 states. The hot spots in the United States currently are Arizona is one that's spiking. You can see the curves for each of the states listed here. Florida is going up, South Carolina is going up, California has been trending up. Wisconsin has been kind of trending down, so we had reached our peak. Our first case in Milwaukee was March 13th, and our peak was at the end of May, and then has been trending down since then. Now, during this time period, I was put in charge for describing and building a data dashboard for monitoring the surge capacity of our region. And this has been important because for our kind of emergence from the first wave. And as we start to open up, we've developed some metrics that might be useful or helpful for places that are thinking about how to open up and so forth. So here you see our county dashboard, and I can zoom in here into our county. We have we're able to actually see hotspots within the city. Interestingly for us, the south side of the city is largely Hispanic. There was a huge hotspot in the north side of the city, which is mostly African American. And so it's really our African American and Hispanic populations that have been hit very hard with COVID. Now this is starting to settle down now, but you can see in our county we had 10,000, almost 500 cases to date. This is as of this morning. This is the racial diversity in the number of cases. As you can see, the Hispanic population has really grown, although the number of patients that wound up needing to go to the hospitals has actually been falling precipitously. The deaths have been initially were much higher in the African American group, and then it has evened out between whites and blacks, and then the Hispanic population is starting to rise. So this has been important information, and this is information that's been provided by the county. Now, specifically, the information that I've been working on and have been providing a regional database for is the surge capacity. So in this dashboard here, and this is publicly available, so if anybody wanted to look at this as a reference, the Milwaukee County COVID dashboard is basically what you would just need to Google, and you can look at this very easily. This is we broke up our hospital capacity in our range here, as you can see in the yellow kind of horizontal lines here. And then we decided to look at a few metrics. One was the percentage of beds in use by COVID positive patients. So that was we thought was an important trend to identify, you know, and change potentially our phases as we were expanding our numbers. And then here we have total ventilator usage, ICU bed, and then floor bed usage, non-ICU beds. Now you can see the numbers have been increasing actually steadily, but this is due to the non-COVID patients as we start to reopen our hospitals to more elective types of cases. So as you can see, the percentage of COVID patients has been steadily declining here, which is an important, I think, metric to have. And then you can see the range of our hospital capacity. And this is not just for my hospital, this is actually for the entire county. Within the county, we have 8 hospitals that provide care for, you know, for patients. So taking that all into consideration, and actually these are competitive, you know, systems and hospitals and so forth. And through COVID, we were able to bring all this information together and really provide a public-facing picture. Now, I have individual hospital information, which I think is important because we were meeting on a regional level to understand individual hospital surges and surge capacities, so that we were able to then potentially shift funds or shift resources or shift patients frankly, from one competitive hospital to another competitive group. So it was a fascinating process to be part of, and it's still ongoing in terms of the monitoring of this. Now, I'll end on kind of discussing the key indicators here. These were key indicators that were used by our county in collaboration with the governor of the state to develop some sort of metrics for understanding where we're at in terms of our responses, and to better inform how quickly or how slowly we should reopen our elective case practices and so forth. Here are the number of cases, and you can see the definitions here on the right-hand side, where the key metrics for cases, we split it up into green, yellow, and red, meaning that green would suggest that there was a decrease and continued negative trends. So we're kind of basically on the verge of green here in terms of the cases. Testing was another key metric that we were looking at as we ramped up our testing capacities. That was another component that was important for us to understand. And we were getting help from the state with some of the testing, as in addition to the hospital specific testing. This is the in terms of what the status of hospitals were in terms of whether or not they were in any kind of crisis mode, meaning that they were in a phase 3, a more advanced phase in terms of utilizing their surge or overflow beds, and then PPE, and then tracing of positive contacts. So these are metrics, indicators that we have used to, and I have to say, you know, there's been a lot of debate about these, and some are better than others, and certainly some of the information is hard to put your finger on, as you've all experienced, you know, in terms of PPE, the supply line, the supply chains being so disrupted globally, that it's been hard to put our fingers on some of these numbers. Also, when you're dealing with large healthcare systems, the way the consumable products are shifted within hospitals, within a system, also needs to be taken into consideration, because some of the systems that we have, and as I'm sure in other parts of the world, where you are extended beyond states, so you're across large regions, and then you're shifting supplies within that system, and that's hard to really capture sometimes at the local level, in terms of understanding where you are for supplies like PPEs. So that's really what I wanted to focus on, and what I was asked to kind of focus on in terms of our surge capacity, our planning, as well as our tracking, more importantly, and then also the indicators that we've started to use as we've opened up our practices. Currently, the state is in a state of opening up restaurants, opening up public places more widely. We still have limited numbers of openings in terms of the restaurants being open to 50% capacity type of thing, and then and certainly we're not having any large gatherings in the state for you know, sport events and that sort of thing as of yet. So that's where we're at. Happy to obviously take questions as after I guess the other panelists are done.
Dr. Moya, thank you very much for your presentation. You showed something very important. Data is crucial, right? It's key for management of the response, not overwhelming one hospital, try distribution patient throughout the system. I'm going to discuss this afterwards. Thank you very much. Now I'd like to go to Dr. Hayato Kurihara. Dr. Kurihara is an associate professor and head of emergency surgery trauma at University of Milano, Italy, and Humanitas Hospital. Dr. Kurihara has been with us for 16 weeks. And the first meeting was 16 weeks ago to him at my hospital. And then after his information, we decided, listen, we need to share this information. A lot of people decided to start this conference. Dr. Kurihara was with us during the acute phase in Italy. Then when the situation in Italy was more controlled, now he's going to talk to us what's happening after reopening. The football, soccer is back. So Hayato, what's happening? What can you teach us about reopening in Italy? Thank you.
Thank you, Antonio. Hope you hear me. So first, sorry, I'm not associate professor. I'm striving to do that, but not yet. So anyway, yeah, soccer is coming back, but without public. And my team actually is not doing really very well, so quite sad. So, but anyway, okay. So this is the situation right now in Italy. We had a lot of death. We had almost 240,000 cases of COVID-19, and we had more than 33,000 deaths. As you know, it has been a huge mess all over here, especially in the north part where I live, in that it's northern Italy, especially in Milan and Bergamo area. And as you can see, we had quite few deaths of quite young people. So 2.7% in the age from 50 to 59 years old. But the good news now is that we started to make more and more tests in the past weeks, but the positive tests now are very low. So we have been reaching our peak around at late March, and it all started, as you remember, at the third week of February. So this is just to give you an example. This is the situation of intensive care. So that was May 1st. May 1st, we were still really crowded, but we knew that we had been reaching the peak at that time. So at the beginning of May, we had the release of the total lockdown. And nowadays, this is the very last update regarding intensive care unit. We could discharge in our hospital, we discharged our last COVID-19 patient last week. So it was quite good news. Nevertheless, in my hospital, we have already been building a new hospital just in case. So, and it will be open within 2 weeks. So, so that we will be able to face possible second wave. Because what we have been experiencing is that to reboot the hospital had been really very challenging. So this is an overview on the ambulance request. Our 911, I mean, in Italy is 118. And as you can see, the highest request, this is related to the northern part of Italy. It's not a slide for all Italy, just northern part of Italy. And this is the peak, it was on the third week of March. And actually, as you can see now we have less call from the ambulance rather than before the pandemic situation. This is a total graph of what's going on in Italy. The blue one is the healed number of persons. The green one is the graph regarding the people that are in quarantine at home. Yellow at hospital. You might see the very small orange stripe. That means the ICU. And this is the total number of deaths. As I told you, we had the first lockdown at the first week of March, and we released the lockdown at the beginning of May. So, and now we are just here. So at the moment, very few patients. So, but our lockdown was released by different steps. We had a first opening at late April, but the last one was totally released on May third. But this doesn't mean that we do not have restriction. But as you know, we couldn't even travel between one region and another region. So the restrictions at the beginning were really very hard. So no flights, no trains, very few people by vehicle. So we had almost zero motor vehicle accidents. We had an increase of, as you know, of suicide attempts and penetrating injury, self-committed mainly. And now we are in a very good position at the moment. But just recently, a couple of days ago, we had a hotbed in the southern part of Italy. This was due to the fact that 10 people from Bulgaria came in. Some of them were infected, so we had a new hotspot. And now, at the moment, there is a lot of concerns regarding this hotspot. So we re-established a red zone. So that zone, it's totally locked down at the moment. We have been trying to, our government have been trying to educate population with a quite aggressive campaign, not regarding also restriction in general, but how to go to the restaurant, because now we have a lot of social distancing also in restaurants. So we have this glass shield between tables. It's quite sad, but we have been teaching population, the government have been teaching population also on how to make homemade protection masks and so on. How to throw away all the devices and so on, scrub hands and so on. I just wanted to report what we did in our hospital network. In the northern Italy, my hospital is part of 7 hospitals. I work in the biggest one. And we started to have this so-called COVID care program for the employers. And I think that this is quite an interesting data, because almost all of the personnel of our hospital have been tested with IgG on 4,000 people almost in 7 different hospitals that are located across Lombardy region. And it was interesting to see, this is in the green one, this is my hospital, which is the main hospital, all the other 7. And we have a positive test with the IgG. So 9% of our employer develop antibodies. But if you see this red square, these are the 2 hospitals where there was the highest incidence of COVID. In this hospital, 2 months ago, there was 1 death per hour. So as you can see, also our employers got in contact with the disease. So 42%, almost 43%, and 35% in these 2 hospitals. So most of them, they were totally asymptomatic, of course. Yes, and now the restrictions are still ongoing, and probably at the end of June, we will be allowed not to use surgical masks when we go outside. But still now, there is a strong suggestion to wear surgical mask. Just a very short update.
Thank you, Dr. Kurihara. We saw through your presentation the difference in the phase, the stages, the acute phase, and now where we are. I'm going to have a question for you regarding surgical masks later. So let's go now to our next presenter, Dr. Tina Gaarder, from Director of Trauma, Consultant General GI and Trauma Surgery at the Oslo University Hospital in Norway.
Thank you, Antonio, for inviting again to give an update. I think I thought the two previous presenters would show all the graphs, and the graphs would be very similar. So I actually dropped making graphs from our side. But obviously, our government is also monitoring the situation very closely as we are opening up. So our numbers so far is actually, they're not that different from last time, a couple of weeks ago when I presented. We have a total of 8,700 COVID positive, COVID positive, tested positive until now, since March. Our population, total population is close to 6 million. We have had a little bit more than 300,000 tested. We have, until now, 1,100 who were admitted in hospital and 220 admitted in ICU. So very much lower than the most skeptical prognosis in the beginning, and the plans from the government. And obviously based on the situation in Italy before us, our government was able to shut down and be strict from the beginning quite early. And they've also been able to open up quite a lot over the last few weeks. At the moment, we are at 4 patients ventilated in ICU, country-wise. Our death so far is 244. I think it was a little bit more than 200 last time, a couple of weeks ago. So very few patients now die. Our median age of patients in ICU so far have been 62, like Hayato was presenting from Italy, but and the median age of the ones who die is 82 years, as with everyone else. For the last few weeks, and I'm just going to tell you a little bit about how we've opened up. The last 2 weeks, only 1 patient has died every week from COVID. We are less than 100 new cases per week, so we're somewhere around 80 cases per week, countrywide. Most of them are occurring in the capital area, where most of the population in our country lives. So what we, more than 2/3 of the ones who have died were above 80 years, very few less than 50 years old. So at the end of April, we started, our government decided to let us, until then we were not allowed to even travel, like Hayato was saying from Italy, we're not allowed to travel between communes, we were not allowed to go to holiday homes in Norway, and absolutely not to travel outside. End of April, we were allowed to travel within the country again. Beginning of May, so the opening has been every 2 weeks, they open a little bit more in order to see the effect of what they did last time around. And in the beginning of May, they started opening restaurants, allowing for alcohol. I mean, alcohol has been sold in the country, and so there's never been an alcohol ban, but no alcohol was served outside. Alcohol was again allowed also in restaurants when they opened. At the end of May, they opened schools, kindergartens, not completely universities, and universities are still not completely open. Medical practices and so on were also opened end of May. And then from now, mid-June, they started opening for sports. So now we have sports events are going on. They're allowed to train together without social distancing. So there are some exceptions from social distancing, but all over, social distancing is still a very strict rule. Until recently, we were not allowed to be more than a few people in private gatherings. Now we're up to 20. For bigger gatherings, we're allowed to 200, and government is saying that the first possibility for opening for 500 people together would be 1st of September. They have developed an app where quite a significant part of the population actually downloaded an app where government can follow where they are and at what distance they would be from other people, and which shows that the social distancing is much less. They're following less than before, so it's quite often less than 2 meters. So the people are getting closer together than they were. And since mid-June, I mean, it's beautiful weather in the country, and that means people will gather in beaches. They are gathering at outdoors, serving in restaurants, and so on and so forth. In the meantime, we are up to completely, actually, no, I think full numbers of elective surgery, back to elective work. They're still strict on pre-triaging, on screening patients and testing. There's a good availability of PPE now. There's good availability for testing, but we don't routinely test our elective patients. We will, we are urged to also to talk to our patients and ask them to maybe isolate themselves the last 2 weeks before surgery, but we don't routinely test every patient unless they have symptoms. With the monitoring of all this, going back to mortality, the country hasn't seen any increase or any surge of non-COVID related mortality during this whole period. And we do not see a surge yet, and our statisticians and the prognosis makers nationwide are not, well, the last prognosis was that they don't really expect a big second surge, but they're monitoring it and they have robust plans for shutting down when needed. As for trauma, we had, I said last time as well, we haven't had any COVID positive trauma patients since then. Trauma is back to normal and supranormal because people have been quiet for too long, so they need to be stupid again. We are a quiet country, so our violence is not that prevalent, but we haven't evaluated all those numbers yet. I think that is most of what we end up seeing, and we will monitor, and we will see probably since the last opening up and the most fundamental opening up was mid-June. We are a people, I think the Norwegian people are quite good at obeying orders. And we have, there's a lot of distance or a lot of space in the country. So I think people are still trying to keep their distance. And we will see over the next week how much social distancing or less social distancing will have an effect. And I think that's, and I'm happy to report back in a couple of weeks again. Thanks.
Thank you very much, Tina. We're going to discuss this in the question. So there's some difference in management between Norway, Sweden, and I heard that there's some question about social distancing or not. So I'd like to ask this question to you afterwards, okay? Thank you very much. So let's go to the pool of questions. Valeria, can you launch that, please? I'm gonna answer these 10 questions very quickly, then I'm gonna start discussion between the panelists. First questions, does your country has this social distancing in place right now? Yes, it's being respected, yes, but not being respected. No, had, but is already in the reopening phase, or you don't know. Okay, number 2, is your country or region in a lockdown situation right now? Yes, is respected, no, or never happened. Question number 3. How is the curve of COVID patients in your area? Is still increasing a lot? Is slightly increasing? Not, is in plateau? Is slightly decreasing, very decreasing, or don't know? Okay. So we're doing the same question for the last few weeks. So you can see that in areas like Miami or California or other states, how they're going to be happening. Number 4, to have guidelines and protocols to treat COVID patients, or any physician can treat it the way they want. Okay. Number 5, every single healthcare professionals in the emergency room and trauma bay are wearing N95 masks. Okay, do you have any N95 masks available for everybody, and are they wearing that? Number 6, what kind of treatment do you give for patients that have a positive test, but they're not symptomatic and not sick, and you discharge home? What kind of medication to give to them? Please just put everyone that they're using. And next question, number 7. For the patients that are symptomatic and need to be admitted to the hospital, to the floor, not in ICU, to the floor, what kind of medication treatment do you give them? Okay. Number 8, for the patient need to go to intensive care unit, okay? The ones that need to be in the intensive care unit, what kind of treatment do you give to them? Number 9, from all the treatment that you give to the patient, what do you believe that makes patient improve? Or to truly believe that makes a difference in the treatment? Okay. What do you think that you use and works? And number 10, last question, what for all the treatment that you are using or using before, what do you think that really doesn't make the patient improve or did not make the patient improve? Okay. Okay, after I answer all these questions, please press submit, okay? Please submit so all your questions or your answers can go to Valeria and you have the percentage of the answers here. Okay, so now Dr. Fornini, could you please just quickly review the answers of the pool questions, please?
Absolutely. Valeria can put the questions up. There we go. Perfect. Okay. Does your country area have social distancing practice in place? And 61% said yes, but less than 50% respecting it. And this has been a shift over the last couple of weeks where we saw people were respecting it more frequently. Does your country area have lockdown procedures in place? No person may live at home unless a healthcare worker or other essential professional. And 45% of the panel said no, and 27% said yes, but respecting it less than 50% of the time. Where does your area, region of practice fall on the curve of daily COVID-19 positive cases? And almost the majority, 48%, stated that's still increasing exponentially. And I'll just make a point that it's surprising that if you go back, people are not respecting social distancing by answer number 2, and almost half the country still are increasing exponentially. So this raises a real issue. And as Mike Abutanos mentioned last week, the majority of people stating that they are using a protocol, so that's very good. 73% of respondents answer that. Are ER and trauma providers in the facility wearing N95 masks at all times during trauma or ER care? Roughly half of people, 52%, answered that yes, and it seems the majority of healthcare providers are using them most of the time, for a total of 82%. What are the first-line medications started early? And the majority of people answered paracetamol, roughly half, 45% of people, followed by azithromycin and then steroids. It's kind of surprising that hydroxychloroquine and azithromycin are still high on that list. 30% stated unknown. When we get into treatment, patient admitted to the hospital, the vast majority, 55% answered VT prophylaxis, followed by prone positioning in these patients, and azithromycin still high on the list at 36%, and steroids is gaining traction here with 27%. Be interested to see the impact of dexamethasone in the near future in these patients. On the 8th question, patients admitted to the ICU, first-line medications, again, prone position has been rather prevalent, VT prophylaxis. Steroids is much more common in the ICU setting, and full anticoagulation is about 20%. About half the patients are still using some type of antiviral medication, and about 15% convalescent plasma in this group. Please select the medication treatment they're using or use that believe that make patients improve. And here, 58% think that steroids, and I think this is a distinct change from last week. followed by prone positioning, 55% of the patients, of the respondents, I'm sorry, and VT prophylaxis is very high at 39%, and also full anticoagulation. Finally, which medications did not make patients improve? Overwhelmingly, 61% are answering hydroxychloroquine, followed by 48% answering azithromycin. And those are the two main outliers in this group.
Thank you very much, Dr. Fanini. Dr. Coimbra, looks like the reopening in Europe is moving smoothly and better than here in the United States or even in South America. So what do you think is happening, Dr. Coimbra?
Thank you very much, Tina and Hayato, for sharing your data. I think that the differences are several. One is related to what I commented on last week, is the leaders in those nations, they go on and deliver a consistent message. There are no mixed messages. You know, just as an example, in our country, the president says, I ask people to test less, and the highest scientists in the country, the most important scientists in the country said, no, we are going to continue to test more. The president doesn't use a mask, and then the public health officials say you need to use a mask. So we get a lot of mixed messages here, and the public is divided. So I think it's the messaging from the leaders is the most significant aspect of this that shows clearly the differences. The severe lockdown in Italy really worked. Hayato was desperate 10 weeks ago, and look at how healthy he looks now. But that's the reality, you know, the message is number one. And two is the commitment of the public and the education of the public. We have a very diverse country, and you know, it's free. We have the liberty to choose what we want to believe, and mandates don't go very well in America, and that's a problem. So we see the differences, I think, primarily because of those two issues.
Thank you, Dr. Coimbra. I'm going to make a question to Dr. Carlos Starling. Dr. Carlos Starling, in fact, is from Brazil, and Brazil has been a terrible situation. The federal government and the state governments and city governments, they have some difference in management, etc. And Dr. Starling's state was one of the one that doing good. But I just read the news that yesterday they had a record of deaths in his state after reopening. So Dr. Starling, maybe you can share a little bit of data from your state and your comments. What's happening in Minas Gerais and Brazil, Dr. Starling?
Well, thank you very much for inviting me for participating in this so fantastic panel. And in Minas Gerais, I would like to share with you some information here, just to show what's happening here. Are you seeing the data?
Yes.
We have here in Brazil right now, and Brazil is a very huge country, and we have different epidemics happening right now. The epidemic start in big cities like São Paulo, Rio, and some touristical cities like Fortaleza, and in north of Brazil in Manaus and Belém, in Amazon forest. And the epidemic starts also in classes, in social class A and B, and rapidly spread to classes, social classes C, D, and E. And like United States, we're a huge country, and we have different epidemics happening in different areas of the country. And like Dr. Coimbra said, mixed messages are very dangerous in an epidemic. And in Brazil, we have a terrible situation. The president says something, the governor say another thing, and the mayors did another thing. So the approach were not similar in different regions. So in Minas Gerais, we developed this kind of panel here where we show the speed of epidemic, the R0, and we have a very high risk of explosion of the number of cases. We have a curve growing very, increasing. The number of cases are growing up very fast in several areas of the country. In Minas Gerais, our state, just to show where we are state, this is Minas Gerais, here is in Central, and I'm located here in Belo Horizonte. It's just in the middle of the state, and approximately 500 and 600 kilometers from Rio and São Paulo. And in our city, we established social distancing. Was not a lockdown, but something like a lockdown. We closed almost not to essential activities in the city. And we contained the epidemic. And right now, in Minas Gerais, we have 29, almost 30,000 cases, and the curve is growing up very fast. And the R0 is 1.6. The epidemic is accelerating right now in most of our regions. And in Belo Horizonte, we start off planning our activities. In January, we started training personnel and preparing the hospitals and establishing training people. And in 18 March, the mayor established one rule that enclose most of our not essential activities, and we reverse the curve. We project the number of cases of almost 4,000 cases in 25 or 30 days, and we reduce the number of cases, and we flat the curve, and we control the epidemic just on the beginning. But in 25 of May 25, we start opening gradually the commercial activities, and now we have the epidemic growing up very fast. This is the curve that we have. The number of the curve is going up, and the R0 is 1.4, and now in Belo Horizonte we have 4,000 cases, and Belo Horizonte has approximately 2.5 million inhabitants, and we have now 4,000 cases confirmed and 96 deaths. It's much more controlled than São Paulo and Rio and Fortaleza in Manaus that didn't have this kind of social distancing, the same approach that we have here in Belo Horizonte. That's our situation right now, and if you need more information, I'm very glad to or happy to share with you.
Thank you very much, Dr. Starling. I actually had a question that came up during from one of the participants, and it was asking for comments, please, about dexamethasone use in COVID-19. And I would like to ask Dr. Barrera his experience with steroids and what's his feeling about the recovery study that talked about dexamethasone.
Well, as you well know, we started using dexamethasone at the beginning of our close to 90-day experience. Then we decreased after all the studies saying it was not good. So now we're under discussion, and we're actually waiting for the paper to be published, because this paper has, it's all been press releases, it's even in Nature Press, but we haven't seen the paper. So everybody's intrigued in seeing the methodology that they used. My gut feeling is that probably we will be using dexamethasone in the ICU at least, if not in the other patients that are admitted to the hospital through the ER. But I think I still need to see the data, and I think that's the position of everybody here in Northwell. You know, as you know, we saw 10,000 patients. We have very large data base. We're looking through all the data, and we will have some publications in the near future. We don't want to be the first ones to publish, because we already were burnt by publishing some data that was not that accurate in the middle of the pandemic. So answering your question, it probably is going to be used, but we have to look at the data closely.
Clearly, you highlighted a big concern. It came out on the lay press before it's been actually published. So people ask us all the time if we're going to use dexamethasone in their loved ones, and it creates more confusion for the population. I think that we were irresponsible as a community to put it out first for CNN, BBC, lay press, and not put it in one of our medical journals. Your thoughts?
Yeah, I totally agree. We have to see the paper, look at the methods, see the results, see if the statistics are okay. Because as Mark Twain said, there's lies, 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 and then there's statistics. So we just have to look at the paper and look at the data. And I just want to mention another thing about the trauma surgeons using N95 masks. Our policy now is everybody that sees a patient that's hospitalized should wear an N95 mask and a shield. So we're taking no chances, because we've been burned many times. The patient is COVID negative at admission, and then 3 to 5 days later he converts. So we're using an N95 mask, a second mask on top of the N95, and a shield for every single patient. Not full PPE, but at least the mask and the shield.
Very good, thank you. Next question is for Dr. Gaarder from Norway. Can you just highlight a little bit the difference in the experience between Norway and Sweden? Sweden took a very lax stance and said that they were going to get quickly to herd immunity. And the reality is, it looks like their numbers are far worse than the rest of the Scandinavian countries. So if you could please comment on that.
Yeah, well, you should never ask a Swede or a Norwegian to talk about the other. Because that's a long-term relationship. But I think what we have said all the time is that we see there was a different approach in the beginning. It's not that the advice was not given by the government, but it wasn't put out as maybe not as strictly as rules as it was in Norway. And the numbers are definitely different between the two countries. So in a way, it helps Norway to be sort of accepting of the way our government has been running the situation. And at the moment, we are since last week, we are allowed to travel in the rest of Scandinavia except Sweden, because of the numbers in Sweden. We'll just have to see how it goes now with the sort of less social distancing. I just want to comment on one thing from the poll, when it says that most of the respondents are saying that social distancing is being practiced, but respected by less than 50%. And I think that's probably one of the biggest problems. I think if we're opening up, I think the main job is for us to be role models and to make sure that people actually respect social distancing and hygiene. And I think that will make it much easier to open up most places. I think that's the most crucial, and that people with symptoms are staying away, that they stay at home if they have symptoms. I think
Thank you. Yeah, Tina, I have a question for Dr. Ken Beaufort from South Africa also. Ken, the numbers, how are the numbers in South Africa? And you guys never had a huge first wave, so it's still the same. So what did you do to control the situation in your country, Ken?
Just before I do that, and to pick up on Tina, until various lockdowns, I've actually been working in Sweden. And And the Swedes, as Tina said, initially were going for herd immunity, but they made a couple of errors, and their epidemiologists have admitted that, one of which is that they did not protect their older people. So the situation was that there was a lot of open space and everything else. Sweden is 10 million people, so about 50% more than Norway. As of today, there have been 60,000 coronavirus cases in Sweden with 5,000 deaths, and their curve is going up exponentially. What I will try and do, oops, that's not what I was looking for. I'm just trying to share a screen to answer your other questions, and thank you for allowing me to do that, if I can actually see where I'm going, but maybe not. South Africa is a very interesting situation because the lockdown that we had, the first case we had on the 4th of March, and the lockdown, our so-called stage 5, on the 23rd of March. And it was total lockdown. You stayed in your house, you got arrested by the police if you were found walking on the street. All alcohol was banned, all tobacco was banned. We have the biggest black market in cigarette sales in the world, I think. However, we are now on our 100th day of lockdown. Now, the lockdown is now at stage 3, which allows more businesses to open and so on. But economically, the country could not stay on lockdown beyond what we're talking about. We're running at over a 50% unemployment rate at this stage. It's a developing country, and it was bankrupting the country. So the lockdown has opened up. To put it into perspective, we're 60 million people, so something like 10 times the size of Norway. Until 3 weeks ago, in the Johannesburg area population is 12 million. We had 1,000 cases and 22 deaths total. And the country at the moment, since the beginning of June, as the lockdown has eased, we currently have just over 100,000 cases and 2,000 deaths, of which more than half are in the area around Cape Town. So we're running about a 2% mortality, but we're in the unique situation of the lockdown was so draconian that it stopped COVID pretty much in its tracks until it was no longer possible to stay locked down. People were starting to ignore it. The national market in pineapples went up because that's the best medium for brewing your own alcohol, apparently. And now the pineapple market is dropping out. Alcohol is now permitted on Mondays through Thursdays. You cannot buy alcohol over the weekend. You still cannot buy cigarettes. We still have a 50% unemployment rate. Our doubling time has dropped from 14 days down now to about 8 days. We can't explain why 50% of the total cases are in one city area. But our first surge is starting now. The good news is that we've had 3 months warning ahead of everybody else. So we have enough PPE in most places. We have enough ICU beds in most places. We have enough hospital beds, at least for the moment. And we've had 3 months to look at the rest of the world, shake our heads perhaps on hydroxychloroquine. We use steroids only in those patients who are sick enough to start needing ventilation. We found a use for ECMO, but we are at the beginning, and we're expecting our very first peak to peak at the end of July, at the beginning of August, and hope that we've learned enough from the rest of the world to be able to keep our mortality rate to 2%.
Thank you, Ken. So Marc, you saw that Hayato and Tina, they already went over the acute phase, and then now they're reopening, but still in the control situation. Ken from South Africa has been, the first wave is still to come, right? South America in the middle of the first wave, terrible situation. And when what Carlos Starling said, that some places in Brazil that are doing okay now that they reopened, they're not doing okay anymore. So what are you gonna say to the leadership in Wisconsin? Is coming, the second wave will come, and how will you prepare your hospital to the second wave? They're gonna happen 2 weeks, 4 weeks, and how bad do you think they're gonna be the second wave at your place?
Yeah, so I mean, some of the lessons one of the lessons that we learned, you know, directly impacted the finances of the hospital. Actually, in the first wave, we emptied our hospitals out completely, and we were functioning at about 30–40% capacity for about 60 days, and it took such a huge toll on the hospital. And then we started seeing patients because they were afraid to come in, primarily with worsening emergent surgical issues. People dying from heart attacks, people dying from strokes at home, coming in, you know, with days of peritonitis because they were afraid to come in. So we actually developed a public service announcement, you know, to remind people that we were taking steps to keep them safe when they came into the emergency room as much as possible. And I think, frankly, people probably had a higher risk of going and getting COVID at the store than in the emergency room, because we were so careful. But so that's a message that I think is important, related to you know, what was said before by a couple people regarding the messaging. It really does boil down to that message, you know, from local and regional leaders in addition to national leaders. You know, the minute you start having differences of opinion and people are not all on the same page is when it's very easy for the issue to then become politicized. And that's what's occurred in the United States, where in essence it's become a Republican and Democrat, you know, issue. If you're wearing a mask, you might be a Democrat. If you're not wearing a mask, you're a Republican. You know, and so it's become a very polarized and political issue, which it shouldn't be, right? And so that messaging is really important. So thankfully, the governor of our state has been listening to the public health officials and has been having a more careful approach to opening up. I think that moving forward and preparing for the second wave, one thing that was really important was maintaining the regional coalition, in essence, even between you know, competing healthcare systems or different hospitals, is, I think, going to be really important, so that we as a region understand and you know, and identify outbreaks before it gets way out of control, and then also using that information to inform our local leaders and the public. I think that and in addition, as I've said, you know, where we shut down the hospital completely, I think we need to be more careful about that. I think that we should be maintaining our capacity in the hospitals. We should be doing especially time-sensitive types of operations like cancer operations. We should be doing certainly any emergent cases, which is an easy case to make. But and those that are purely elective, you know, perhaps some, you know, aesthetic types of operations, or, you know, those purely elective operations, bariatric surgery, perhaps, you know, that can, you know, wait. But we should not be closing our doors to patients, and we should be thinking a little bit more carefully, as we are, about maintaining the capacity and remaining flexible, though, in terms of how we may pull back, you know, elective cases or semi-elective types of cases to open up more beds. So those are some of my thoughts and some of the lessons that we've taken from the first wave, as we start to prepare for and monitor for the next wave.
Very good. So this is a question.
Antonio, may I ask a question to Tina? Tina, you mentioned that you guys are not testing elective surgery asymptomatic patients. What is the rationale for that decision, and what is the risk of asymptomatic carriers during parts of the procedures that lead to aerosolization to infect the team?
I'm just, I think the reason was, I think it is being done, but it's not a routine that is being done. It's not, so it's not, you're not, our hospital managers are not saying that every single patient for elective surgery needs to be tested beforehand. Also because if you do that, when are you going to do it? 72 hours before? It still might be positive at 24 hours before. And so on, because of the test and lack of validation and so on and so forth. I think, and as personally, I think if talking with the patients early enough and making them understand the importance of actually self-imposed quarantine or isolation before elective surgery is as important, if not more, than doing that testing. It's not by the lack. It's just not being sort of enforced that every patient has to be tested. We asked our management about this early, whether this should be a rule, but at the sort of on national level, it hasn't come down as the rule, and it hasn't translated into more risk or more infected personnel or so on because of the very, very low rates.
I think that I think it would actually be probably partially a function of the prevalence within the community as well. Because if your prevalence is very, very low, then it's probably less important. We have areas in our city though that are 45% positive testing rates, and so so we are testing all of our patients. Any patient that gets hospitalized or has an operation, we are currently testing with a rapid turnaround test. If it's somebody who's an outpatient, then we're testing, in a batched way so that we can, save on the rapid tests. But yeah, so that prevalence may actually be, important there as well.
You're at the stage
now. I think it affects how the PPEs that you use for surgery. If you don't test anyone, or if you test sporadically, everyone should be using an N95 with a surgical mask on top, face shields, maybe PAPRs. So if you have all that resource, that's great, but then you need to use them consistently, because just by asking people, hey, do you have a fever? Were you coughing 3 days ago? Or have you been in contact with somebody with COVID? Won't protect you with a simple surgical mask.
I think there is a difference. There are different opinions about this as well. And again, a little bit about the prevalence and the risk and the frequency of infected patients. We do not run with FP3 or sort of high level masks for surgeons who are not operating on the airways. So abdominal surgery, that is not something that the surgical team would use. And I mean, even if we have good resources when it comes to PPE, those masks will be limited and are a limited resource, and should be. And if you look at, again, back to the statistics and back to the positive rates and infected rates and so on, we see so few patients now that this is where we've ended up being a little bit more judicious about the use of that kind of PPE. Resources. We also had recent discussions around who to test. So we've been testing every single trauma patient who cannot answer the questions, the screening questions. So every single trauma patient was tested until recently. Every single emergency medical, surgical trauma patient who could not sort of answer these questions properly. And we've had so few of them testing positively. They were also isolated until the answer of the tests and so on, and using a scarce resource is also the isolation beds for those patients and so on. And going back and again, the monitoring groups in the hospital have also seen that there's so few of these patients who are positive that they have dropped since this week. They have dropped doing, so if patients are answering positively to the questions, the high risk questions, they will be isolated, they will be tested. At some stage, all emergency patients will be tested but not isolated. That is also being discussed at the moment. So they will all be tested but not going into having separate rooms until the answer of the test is available. So I think it's just being at different stages with different prevalence of the disease. And I think it's also being rational, not being paranoid completely. And I think, and also being in the same groups and not having different rules for different departments and so on, having a very clear leadership in the hospital, on the government level, and saying this is the risk and this is why we are deciding this, the rules on different levels.
Tina and Hayato, so a quick question. So one of the most important things that patients complain about is not when the elective surgery not allowing them to have visitors, right? We are almost ready to reopen for visitors. The hospital now they went back, no visitors in the hospital. So what's happening in Italy and in Norway? And Raul, what's your policy right now in California with the increase of new cases about visitors for elective surgery? So Hayato, Tina, and then Raul, please.
Okay, we still have a very, very restricted policy on that. So till now, no relative is allowed to come in the emergency department and in the ward. Very restrictive. But we have also a very strict rule to get into contact with the relatives at least once a day. The only parents that are allowed to come to the hospital, they need a special permission from our medical direction, and it's mainly just for terminal ill patient.
I can just copy Hayato's answer. Exactly the same here.
Exactly the same in Brazil.
Yeah.
Mainly in our hospital, in the 3 hospitals that I work with. I'd like to ask you a question. May I, Dr. Martos?
Yeah. Let's Raul ask this question. Then you make your question, please, Raul.
Okay.
Yeah, the visitation policy is very similar to what Tina and Hayato described. We were about a month ago, after we thought we had dealt with our first wave, which in fact I don't think we have, but I think we still are in our first wave. But we were pretty down in numbers, and then we start to climb again. We were about to change our visitation policy, and the numbers start to climb as society opened, and we decided not to. So pediatric patients, one parent is allowed to stay with the kid, particularly if the kid needs care all the time to help with the nursing staff. We test everyone, and including the parents, they have to stay the whole day, and they cannot leave, go to the grocery store, come back. They have to come in the morning, stay until the next morning. And pregnant patients, we have been allowing a partner to stay, which is also tested. I just want to make a point that I think our responsibility as healthcare providers is as much to our patients as it is to ourselves, to maintain the safety of the teams, the nurses, and everyone else. And that's the reason why we adopted a very, very strict testing policy, because 1 or 2 trauma surgeons, for instance, that go down with this disease, it creates a big hole, and we would not be able to fulfill our obligations to the public. So we want to make sure that the environment that we are practicing is the safest possible. And that's the reason why we are having this very aggressive testing policy.
Thank you, Dr. Carlos. I think Dr. Froedtert has some question for you, then you can continue. Dr. Froedtert, please, you have some comment.
Yes, I want to continue with testing, because testing does not mean the same to all people. And I want to highlight and kind of divide it. I would like to ask all the panelists if they can quickly go through what they consider appropriate testing, because it goes from history to doing RT-PCR, which in my country can take 4 to 7 days, not hours, but 4 to 7 days. CT scan, the quick antibody test or quick antigen test. So if I can just get a sense from each one of the panelists, we can start with Dr. Starling, what they consider to be appropriate prior to passing a patient over for either elective or emergency surgery.
It's very hard question, because in the first, the PCR are the preferred test, but I think we should never test a patient without a very good anamnesis and the test, and check about contacts and check about signs and symptoms. And then if you have some indication that the patient had a contact or is presenting some sign or symptoms, just make a PCR just before the surgery, but just before admitting the patient or in emergency unit. And I agree with Dr. Raul Coimbra about using a PPR in a very high level, if you can, mainly with the epidemiological conditions drive you to do that. For example, if you are in an epidemic exploding in your city or in your region, you should use a total PPR to protect the surgeons. We established that in some of our hospitals. And the other tests that we perform is antigen, EGG. We search for EGG to check if the patient had already had contact with the virus and developed the EGG. So in this kind of patient, we are much more comfortable, and I would suggest that these two type of tests, PCR and test for EGG.
Raul, your thoughts?
So RT-PCR is the gold standard. If you batched the samples, you can get our RT-PCR result turnaround time in 4 hours. That's what we are doing. We develop our own internal capability for RT-PCR, and a very highly sensitive test. We are detecting 1 copy of the virus. This is done by 2 molecular biologists that are very experienced. And the turnaround time for us is between 4 and 5 hours once you batched all the samples and to extract the RNA. There is another test, another piece of equipment here in the United States that's called Cepheid, which is a rapid test, which is also an RNA test, not completely a full PCR, but it's based on PCR technology that also has a high sensitivity down to maybe 80 to 100 copies of the RNA, the viral RNA, which the turnaround time is about an hour. And this is what we are using for emergency department cases. Cases that cannot be tested, trauma cases that go straight to the operating room, etc. Everybody is wearing full PPEs and hoods and and double masks and shields and everything that's available. But everyone gets tested at some point, either on the way to the operating room or immediately after, so we don't delay any procedures, but they get tested 100%. And I think this is the big difference between, you know, what physicians, clinicians think about the disease and what public health people think about this disease. I'm all for getting history and physical exam, like Dr. Starling said, all that. But in a pandemic, most of the time with this infectivity rate and the mortality associated with this disease, it has to be all or nothing. And I think, you know, creating too many different classes and too many different pathways in your algorithm will not allow you to have a global understanding of the spread of the disease in your hospital or in your community. And that's why the testing is so important.
Very good. And nobody talked about CT scan on these patients. And one of my big concerns is that the patients, if they are COVID positive, their outcomes after surgery are far worse. So it's also a concern not only for the providers, but also for the patients that we take care of. I don't know if Dr. Hayato want to make a comment about testing.
Again, although it's quite controversial, I understand that we have a very strict rule for that. So 48 hours before surgery, we have a swab for each elective scheduled surgery and a chest CT scan. I know that might be controversial. That's probably too much. As far as I know, in my experience, we picked just one patient at the moment that was scheduled the day after. And the issue is, what about young patients? So we do younger patient, we do chest ultrasound. But, you know, most of our patients are not that young. So still controversial, but we're still discussing, but at the moment, this is our policy in our hospital.
Very good, thank you. Moving on, unless there's some other comment with testing. There's a question here, which test? I think that most are talking about RT-PCR. Problem in Bolivia is the length of time for that. There are some quick antibody tests that are used, but they have very low specificity and sensitivity. So I don't particularly trust them. And we have limited experience with ultrasound, so I tend to get CAT scans on them. And we've been fooled before, unfortunately, with CT scans. But typically, if I'm going to do a belly on somebody, I'll just do the chest prior to surgery. Moving on to Dr. Barrera, a question about social distancing in New York and what's expected as far as the second wave in your community.
Well, social distance has been very interesting in New York City. I live in the Upper East Side, and we started phase 3 today, outdoor dining, and everybody's wearing a mask, sorta, until the drinks come out. And after 6 p.m., for the first time in New York City, you can drink on the sidewalk, which is very interesting. So I think we have to wait to see what's going to happen after this stage 3 with the protests that are going on. We are hoping not to have a second wave or a spike in the first wave in the next week or so. We have not seen it. We have not admitted any COVID patients to our hospital in the last 72 hours, which is always good. And what we're doing is, you know, going back to testing, we're testing everybody. We're doing a PCR on everybody because we have assigned COVID floors. So if a patient comes in COVID positive, we are clustering them in one floor with nurses and all the PPEs. The rest of the staff, you know, we're required to have a mask, of course, and carry an N95 in your pocket just in case you're going to go into it. So we're still waiting, and hopefully there won't be a second wave or a spike after this.
Very good. Thank you. Now, there's been a couple of comments here and questions. One's from Brazil, and you can read it too, but it's from Marcelo Rivera. It says, in Brazil, we're on a boat without a captain. Our president is ignorant and 100% against all scientific evidence so far. And we get a similar response from Mexico. We're in the same situation that you are in Brazil. The authorities don't have the courage to accept that they're wrong with the reopening phase. So many of us, the health professionals, suspect that the statistics are manipulated, because they will talk about COVID situations at hospitals is something different from what we watch or hear in local and national conferences. So I just want to ask Dr. Ken Bulford, since he's far away from the politics of the United States and from Brazil and most of Latin America, what's your opinion about leadership and the handling of leadership of this condition? How much does national leadership make a difference?
You're muted, sir. I'm sorry, you're muted. Dr. Bulford, check your mute button.
Yeah, I'm unmuted. My space bar wasn't working. Our president is on record as saying, it's not like government has just decided on its own. We've listened to the people. Sometimes when we have regulations, if challenges are raised, we may have overlooked, and we're dealing with. And it's like filling a river. You fill it as you cross, and sometimes you slip and falter. Sometimes you find firm ground. We've had to be flexible. We've had to change if the ideas don't work. We have to move to new modalities as soon as they're available. So we have had the ability to change. We've had the world's most severe lockdown. We're suffering effects from that. So I would rather not comment on any other country's politics, because every country in the world has got politicians who say things publicly and mean it, and who say things publicly and may not mean it. So we're all victims of that. Just one comment on something that was raised previously. In South Africa, we now got the rapid PCR, which is for us around an hour and a half. And it meant that those patients who are persons under investigation, PUI, we can bring them in, screen them, and either put them into a green zone or into a red zone within an hour or two of admission. The other is we cannot yet, and I would be interested, get the Roche and the other antigen antibody test. NATO is already using it in parts of Europe. And the one thing that's been absolutely critical is they're looking primarily at the antibodies, because it's being used on hospital staff. And those hospital staff who have got good antibodies are fantastic for the front line, because they no longer have, they have resistance. They have no longer got the vulnerability, it would seem. So it's going to be very interesting as that test becomes more available again to discuss it on this panel.
Very good. Dr. Starling had a question he wanted to ask, so we'll go defer to him, and I think we'll be finalizing the.
Oh yeah, I could not miss the opportunity to ask you all, my colleagues from several countries, about what's happened with the nosocomial infection with this period of time in your hospitals, mainly with multi-resistant bacteria like KPC and Acinetobacter. It seems to me that antimicrobial stewardship was killed by coronavirus. I don't know if you have the same experience with your trauma patients. Dr. Kurihara.
Yes, I can reply just from my hospital. I guess we are quite lucky in our hospital, because we have 4 infected disease specialists. So almost everything, all patients has been stewardship from them. But the reality is that in most of the Italian hospital, infected disease stewardship, it's not really set up.
Dr. Barrera, your comments, please.
So in our experience, the longer the patient stayed on the vent, the higher the resistance of bacterial pneumonia. We saw a lot of Klebsiella and some Acinetobacter that were very resistant. And because we were doing blood cultures every third day for a lot of the trials, the IL-6 trial, the IL-1 trial that we had, we found that a lot of people had Candida also. So the rule of thumb we were following was, as the all the inflammatory responses were going up, the procalcitonin especially double, we started antibiotics empirically because of the sheer volume of patients we had. Remember, the worst day we had here in LIJ time in one day. So there was a lot of delay in testing and everything. So we empirically started a lot of people on meropenem, depending on the levels. And as the white counts went up to 30s and 35s, waiting for the Candida or the fungal cultures to come back, we started them on antifungal also. And that seemed to help a lot of the patients. But a lot of things were empirically, and when we look back to the cultures, we more or less, our clinical acumen, examining the patients, looking at the patient, we were sort of right. But that's what happened to in our experience here.
Marc, any comment, please?
You know what? I just want to make sure I'm not muted. Okay. I don't have anything else different than what Dr. Barrera said, because we had the same kind of experience. Yeah, so nothing really more to add to that.
Thank you very much. I truly believe that Dr. Namai and Dr. Coimbra, they made the same comment a few weeks ago that unfortunately the COVID-19 going to be something going to be like the HIV in the 80s. You're going to learn to live with that. You're going to be here with us for a couple of months and years. Like Marc said today, we cannot see the hospitals closing again for 4 or 8 weeks anymore. So we need to, the hospitals need to keep open. We need to keep doing the procedure surgeries. And a lot of people died at home because they didn't come to the emergency room with his heart attack, with strokes. Oncologic surgery was a problem. So we need to keep moving, because a lot of people that don't have COVID, they're gonna suffer from other more comorbidities or other disease. So it's a challenging time. We're gonna need to learn how to deal with COVID and all the diseases together. But it's still far away to be over. We're gonna be talking about these and learning each other for many time. So I would like to ask again, say thank you very much for Carlos, Tina, Esteban, Marc, Hayato, Rafael, and Ken for being here again. Some of you have been here for many weeks. And stay strong. The message that you all provide is very important for many places around the globe. I hope to see you safe in the next few weeks. In the name of the Panamerican Trauma Society, American Association for Surgical Trauma, International Relations Committee, the World Coalition for Trauma Care, University of Miami, and VCU, Virginia Commonwealth University, I'd like to say thank you for being here. I would like to say thank you for Gladys, Stephanie, Gary, and Valeria to make these meetings happen. And I hope to see you all next week, when we're going to continue talking about the reopening and the second wave. Thank you very much, all. Take care.